let us chase another dreaded post-operative complication, the dangling IOL post-operatively. I take this privilege to welcome my good friend, surgeon with magic in his fingers, a brilliant cataract surgeon from ASG Hospital, Kolkata, to present his talk on the dangling IOL. Over to you, Dr. Manas.
Thank you, Jayashi, for the opportunity. And I'd like to thank the audience for staying for the last show. Yeah. So I'll be talking about the management of dangling IOLs. So this IOL decentration can be seen in the intraoperative period, early post-operative period, and also in the late period as well. So let's see first case scenario. This is a young patient with lenticular coloboma with a high myopia. So my aim was to do a phacoemulsification and placing a single-piece foldable lens within the capsular bag and fixing the bag with a CTR and a capsular tension segment. So after doing phacoemulsification and supporting the bag with the CTR and iris hooks, when I was placing the IOL within the capsular bag, one of my iris hook was too tight, as you can see here, and while implanting the lens in the capsular bag, it got torn at that point. And you can see that the margin got torn here, and gradually it extended to the periphery, leading to a posterior capsular rent with little manipulation. So I just found myself in a situation where nobody would like to be. So the next thing that was going in my mind was, how do I manage the case? Should I go for an IOL exchange with a multi-piece lens? But my bad luck was that that time I did not have the backup of a lower power multi-piece lens, and I did not want to keep the patient aphakic as well. So can we fix the same single piece lens to the eye? Whether, well, it can be done whether to the iris or to the sclera, but suturing a single piece foldable lens to the iris can lead to iris chafing and pigment release. Literature has shown good result with suturing it to the sclera. So I proceeded with suturing it to the sclera. For that I am making two partial thickness scleral flaps exactly opposite to each other, and a straight needle of a double arm 9-0 Prolene suture is placed in the anterior chamber, and then a 20 gauge needle is introduced from a distance of 1.5 from the limbus, and it is placed just below the haptic near the optic haptic junction, and the straight needle will be docked inside and will be taken out as close to the optic haptic junction. And similarly, another straight needle will be taken out for this time above the haptic to form a loop, and the same procedure will be repeated from the other side to make a loop out of here. And once it is done, both the sutures ends are tied and little bit of vitreous was there, so I did vitrectomy, and at the end you will see that the IOL is well centered. And this is a 7th picture also. You can see that eye is well formed, IOL well stable. So the lesson that I have learned from this case is that always have a backup of a multi-piece IOL when you are doing this kind of complicated cases, and while implanting the IOL, and if you are using either iris hook or capsular hook, slightly loosen up the iris hooks or capsular hooks just before the IOL implantation. This is another case where in the intraoperative period the surgeon noticed intra-PCR and he placed a multi-piece lens, but next day there was gross decentration, so it came to me for further management. And while taking up the case, I thought of dilating the pupil and see whether any capsular support is there or not, so that I can place it in the sulcus. So I dilated and check for any capsular remnant, but support was not that great. So I decided to go for iris suturing the mecanal way. One can also do a scleral fixated IOL in this case because it's a multi-piece lens. And lifting it into the sulcus, and then next I have lifted the optic above the iris to do a optic capture. Here you can see that the optic is above the iris and the haptics are below. So now both the haptics will be sutured with a your 90 Prolene suture on both the sides, and both the sutures are taken out from the same paracentesis and will be sutured in the manner of 3-1-1. So one side is done. Next I'll be doing the other side as well in a similar manner. And then when it is done, the knots are cut and IOL is pushed behind. You see that the IOL is well centered and a well formed chamber as well. So to have a round pupil in iris suturing, the location should be mid-periphery. If you go anterior, like near the pupil margin, definitely you will have peaked pupil. Take a shorter suture bites and avoid excessive tightening of the knots. This is a late presentation. Here you can see that the IOL back complex with CTR is decentered both in opposite direction. The primary surgery was done almost 7 or 8 years back. Patient had a subluxated cataract, and the primary surgeon placed a CTR in the capsular bag, but somehow the IOL was not placed in the bag and it was in the sulcus, and now it has grossly decentered. So any of these kind of primary surgery, during the primary surgery also, the bag should have been sutured to the sclera. So let's say how I have managed the case. My aim was to suture both the IOL and the CTR to the sclera. So for that I made two Hoffman pockets exactly opposite to each other, and then the 26 gauge needle is introduced again and a straight needle. Now it has pierced the capsular bag, taking the CTR and the haptic, one below and another will be above. One side done and another, now the other part. Piercing the capsular bag, taking the CTR and the haptic along with that, one below and another above to form a loop. And both the suture ends will be taken out from the Hoffman's pocket and will be sutured gradually. The titration should be gradual so that the IOL remains at the center. And at the end you can see that the IOL is well centered. Little bit of PCO was there, which been managed with later on your YAG capsulotomy. So this is another case of a traumatic decentration of the IOL. Here also during the primary surgery it was uneventful, but the patient had a history of trauma post surgery, and because of which you can see that the IOL back complex has decentered. Now the haptic is over the iris. So in these cases thorough evaluation is also important, because you never know, you can just rule out any vitreous is there or not, any retinal pathology post trauma. So here also I've making a Hoffman's pocket here, and my plan is to suture this haptic to the sclera. Once the Hoffman pocket is made, I have injected dispersive viscoelastic to push the vitreous behind. There was no vitreous disturbance in this case. Similarly, a straight needle will be docked into a 26 gauge needle by piercing the bag. The first needle gone, and now the haptic will be placed behind the iris. Had it been a case of a pseudoexfoliation, I would have sutured both the haptics, but it's a case of trauma. Remaining zonules are quite strong, so I proceeded with suturing with the only one haptic. Now you can see that at the end the IOL is well centered. So this is one of my first case which I did in 2014, and I learned a very important lesson out here. So after placing everything, when I was centering the bag, you can see that both the suture needles are taken out, formed a loop, and when I was centering it, I am trying to center it, and I should have stopped here, but I forced myself to over tighten the knot, and now you can see that the IOL back complex has decentered a lot. So this the important lesson that I've learned is that the suturing tying should be slow and gentle. You should titrate and make sure that the IOL remains every time at the center before your final suture knots. So whenever you're managing these kind of cases, make sure that you tighten up your seat belt, because never know when you will end up in turbulence. So in this case, when I was managing this IOL back complex decentration, I passed again the suture look. When I was centering, I noticed a pre-existing PCR, which was there from beginning, from the primary surgery. So managing these kind of cases is very difficult, because I have to suture this part also, and your care should be taken, because the back should not get damaged further, because it will be very difficult to manage a dislocated seat in this case. But luckily everything went on fine and the patient did well. So to have a proper IOL centration, the fixation points should be exactly opposite to each other, and one should have confidence and patience to deal with these kind of cases, because this will take definitely a little bit longer time than our routine cases. Thank you. Thank you for listening.
Wonderful videos, Dr. Manas, and I'm sure definitely all of us have learned something from these videos. I had a question, like in the iris sutured IOL, which you have shown in your second case, how important is it to do a PI? Because you had already done the optic capture. So is there any incidents where you felt post-operatively that, yes, I should have done a PI in this case?
I've done optic capture just before suturing. So once I have sutured it, I place the lens in the sulcus.
Yeah.
So whenever using a three-piece lens, there is angulation, 10-degree angulation, and when you suture it, the IOL will be a little bit behind the pupillar margin. So unlike when you are placing a iris claw lens, which is very close to the pupillar margin, in those cases you definitely need a PI to prevent the pupillar block. But when you're doing iris suturing, after suturing, the IOL will definitely go a little bit behind, and there will be space for the aqueous to move around, and it will not create your pupillar block.
Okay, so PI is not mandatory.
No.
Okay.
When you're doing iris suturing, not needed. But when you're using a claw lens, it's mandatory.
Okay. And is there any difference that you are using an iris hook for this case, the first case which you have shown? Had the incident been prevented if you had gone for a capsular hook or something like that?
Definitely. I should have gone for a capsular hook, but it was not available that time in the OT, so I proceeded with iris hook. And even then, I should have a little bit loosened up all the hooks, which would have prevented the tear.
Yeah, thank you so much. We have a question.
So did you expand out the CTR after noticing the PCR in the first case?
No. It was there in the sulcus. Luckily, it's a great concern. Thank you for bringing it out. It was there in the sulcus, and I'm following it the patient it's almost 4 years now. Everything is okay till now. But yes, there is a chance in future it may go down, or we have to look out.
So should we expand it?
No, because now it has gone to the sulcus. You cannot take out a CTR which is there in the sulcus. You will damage everything. So only when it is visible, or it has decentered, or it's in the anterior chamber, or it is somewhere in the retina or somewhere, then you have to take it out. Otherwise, it has gone. When it has gone in the sulcus and you don't see, blindly never try. You will damage ciliary body and all.
Yes, sir. On day 2, we have seen this IOL bed complex displacement. So when should we intervene? Like how long we should wait before doing any secondary surgery?
This case I took on the next very day only, because there was a gross decentration idea, and if you wait further, what will happen? The lens may go down further. So as soon as you have,
Day2 would be fine.
If there is no reaction, eyes quiet, definitely you can take it up.
Any precautions should we take before doing the?
Make sure there is no vitreous. In those cases, we usually prefer to give either IV mannitol or oral glycerol to shrink the vitreous. And if there is vitreous, do vitrectomy first, and then go for any suturing technique, because with the vitreous in AC, you should not.
If cornea is not good, we should wait.
Yes, definitely. If cornea is not good, you should wait. You have to wait, otherwise blindly you cannot do. the approach should be like, if you can see the IOL, because when there is SK, when the IOP is raised, you should avoid. I told when the eye is quiet, like cornea is near clear, the visibility is good, proceed.
Okay, thank you so much.
Dr. Manas, do you think vitrectomy is needed, like in all of your cases?
Yeah, in most of the cases there was no vitreous in the anterior chamber or in the pupillary margin. But yes, while like suppose you feel that there is a vitreous in the anterior chamber, we have to do. I mean, I have not used triamcinolone, but triamcinolone is good to visualize the vitreous, do vitrectomy, and then proceed.
Because in all cases they are dislocated, no? So you never know.
Yeah, but the vitreous was not there in your anterior chamber or near the pupillary margin. Vitreous was not that damaged. I mean, the vitreous phase was almost intact.
And in your first case, like you have used iris hook, no? So
yes, yes.
What's the need? Like I have seen a sufficient pupillary exposure. Like why you have used directly? You could have given a CTR and then.
Yeah, because I placed the CTR for your equatorial support and iris hook for the supporting the bag for anterior posterior.
Okay.
Because sometimes while you place the lens, if the back complex may tilt and placing the IOL will be a little bit difficult. So I kept the iris hook just to give anterior posterior support so that the placing will be smooth.
Okay.
Yeah, thank you, Dr. Manas. But I would like to suggest that a take-home message for the beginners who in such cases will definitely to use triamcinolone and go for a vitrectomy, because the experienced surgeon they can know that exactly there is how much vitreous or whether vitrectomy is required or not. But when you're dealing with cases like this, it's good for the beginners that you always go for triamcinolone and go for the minimal amount of vitrectomy that is required.